opening the door wide to new possibilities, hope of real breakthroughs and understanding more big ideas than we could have ever imagined. These are the biggest grants we've ever been able to. We're going to come out of this with some breakthrough ideas.
Focused solely on neuroendocrine tumors. You are not alone. We are all with you on this work.
Welcome again. I'll be talking about systemic management, systemic therapy, current options, and recent advances for neuroendocrine cancer. We're going to cover a lot of information because the advances have been extraordinary just in the last few years, and we have so many treatment options we didn't have before. Could you hear better now? Okay. I'll be speaking about systemic therapy for neuroendocrine cancers, current options and recent advances. I'll be touching on some of the new things that are coming along, and Diane Reedy, who's going to be speaking later on in this session, will be talking in more detail about some of the new trials as well. Okay, a few basic principles just to lay the groundwork. Chemotherapy, biologic therapy, and peptide receptor radiotherapy usually result in stopping of cancer growth or minor reduction in tumor size. A few patients have a major reduction in tumor size, but the goal is long-term, what we call progression-free survival, living without cancer growing, which can potentially extend survival and extend the quality of life. High-grade or poorly differentiated tumors, those that have high Ki-67 or high mitotic rate, are often the most susceptible to cytotoxic chemotherapy. And neuroendocrine tumors starting in the pancreas are often most susceptible to chemotherapy as well. There are all types of biologic therapies we'll be speaking about in more detail, based on the fact that there are many molecular targets on neuroendocrine cells which are very amenable to attack. These include increased blood vessels and blood vessel growth factors that can be attacked by treatments, increase what we call tyrosine kinase growth factor receptors. We have drugs that attack that. There are genes that maintain a malignant state, and those could be attacked. And many other features of the neuroendocrine cells all have specific drugs now that can be used either investigationally or things that are actually approved on the market right now for treatment. Changes on the surface, changes in the items in the cell itself that make it grow faster or slower, things that cause apoptosis or premature death of cells, and even things that can change the rate of metastases. This is to show you the extraordinary progression in the last few years of proven clinical therapies for neuroendocrine cancer. The first chemotherapy ever approved was in the 1980s using a drug called streptozocin, which we don't use too much anymore, for pancreatic neuroendocrine tumors. A study was done in Europe called PROMID with octreotide, showing some benefit, but it was a small study and was never approved for that purpose in this country. And it wasn't until 2011 that we got everolimus, sunitinib, then lanreotide, and now we're on the cusp of peptide receptor radiotherapy becoming an approved treatment. All of these based on large randomized prospective clinical trials where one treatment was clearly proven better than another. Very difficult doing these kind of trials in patients with a rare disease, but they were accomplished, proved their point, and resulted in better treatment. Many people in this room have participated in these trials, and clinical trials are actually one of the few ways we have of providing state-of-the-art treatments that would otherwise be unavailable. Another basic concept in chemotherapy, before we talk about details, is what we call molecular profiling. It's possible to take a sample of neuroendocrine cancer. It can be a pathology slide, a tissue block of pathology that's in the pathology department, and you could analyze for genomic changes that may give clues as to what drug will be useful. And this is becoming more and more widely used, although the data from this is still early, and it's just limited experience, but certainly with other cancers, it's proven to be very valuable. In a study that Dr. Warner was part of, molecular profiling in neuroendocrine tumor, potentially beneficial therapies were identified based on measuring expression of 20 proteins and oncogenes and comparing that with a comprehensive review of the chemotherapy literature. Clinical charts of 41 patients were reviewed, and 12 were selected to evaluate clinical usefulness of molecular profiling when all the data was available. 9 of these patients were treated with drugs that were potentially beneficial based on molecular profiling information, including the drugs capecitabine, 5-FU, temozolomide, oxaliplatin, and gemcitabine. And based on having some clinical or objective improvement in their condition with these drugs, 5 out of the 9 had a response. And this is using drugs that probably would not have been chosen if it were not for the molecular profiling. So there certainly is hope, and I think that more and more data is going to accumulate very, very rapidly, and I think we'll see large series even in the next year or two, so stay tuned. There are certainly problems with this technique. The assays have not all been validated for predicting response to treatment. Sometimes you can select patients incorrectly. It can increase the cost of care. There can be problems in screening very large numbers of patients for a rare one who would benefit. Targets change as additional mutations develop in the course of growth of metastatic disease. So what may turn out to be useful at one point may be less useful 10 years later if you're looking at an early specimen. There are ethical issues raised by tissue biopsies, especially if you need fresh tissue from a liver, for example. And we're trying to identify ways of analyzing blood samples to do genomic analysis, such as being done the so-called NET test for use as a prognostic marker. That type of information can also be potentially used for identifying therapy if you do genomic sequencing on DNA material. So just be aware. I'm, again, going through a large amount of information very quickly, and we'll be able to answer questions and talk about a lot of these issues in greater detail when it comes to our patient discussion and question time. I'm going to mention immunotherapy because it's one of the hottest subjects right now in oncology, and it's starting to be important in neuroendocrine cancer. You'll be hearing from other speakers a little bit later about some very exciting new trials, including the CAR T-cell trial that NETRF and University of Pennsylvania are working on, and trials being done at other institutions. But the concept is that immunotherapy drugs stimulate patients' immune system to attack cancer cells, or you could use infused antibodies to attack the cancer cells, and then specialized white blood cells called T cells can be stimulated in different ways by drugs. That's another type of immune therapy, and kill cancer cells that way. Immune checkpoint inhibitors you're going to be hearing a lot about, and a very important clinical trial using immunotherapy with immune checkpoint inhibitors is about to be started, and we'll be doing this very shortly. Immune checkpoint inhibitors work by interfering with an interaction between a T lymphocyte cell and a tumor cell. This is a tumor cell. This is a T lymphocyte cell. There's a part of the tumor cell that is able to stick to part of the immune cell here. The antigen over here interacts with the T cell receptor. By breaking this connection of PD-1 and PD-L1, it turns on the T cell, and the T cell kills the cancer cell. So you can break this connection right here with all kinds of different drugs that attack PD-1 or PD-L1. Those are the two parts of this handshake, and the cancer cells die. And this turns out to be extraordinarily effective in many kinds of malignancies, and we're now starting to use this technique investigationally in neuroendocrine cancer. In high-grade neuroendocrine cancers, proof is already out that this is very effective. There were 2 major trials presented at ASCO this year, one using a drug called pembrolizumab in patients with high-grade neuroendocrine cancers who had already had progression of cancer after standard available treatments. They had 35% responding. And another study using a combination of nivolumab and ipilimumab, a combination of 2 immune checkpoint inhibitors. 54% of patients had control of their cancer when otherwise it was growing uncontrolled. Again, we don't know yet in well-differentiated neuroendocrine tumors, but those studies are going, and we're very hopeful about it. Adoptive T-cell immunity is something that Dr. Metz is going to be talking about a little later, and CAR T-cells, and what I'm going to do is leave that for Dr. Metz to talk about. Cytokines are proteins made by normal cells that regulate immune response and the immune system's ability to attack cancer cells. Interferon is a cytokine which is effective in neuroendocrine tumors. As Dr. Warner said, it's used less frequently than other treatments, but actually does have its role and can be quite effective. It can cause side effects, namely fatigue, depression, malaise, and flu-like syndrome, which tend to go away if the dose is reduced and often will spontaneously go away as well. But when people get on a dose which is tolerable, sometimes it can control cancer for years and years and years, and can control carcinoid syndrome even when octreotide alone is unable to do that. So just be aware of its existence. Sometimes people never think of it. Okay, the next thing I want to talk about is treatments based on the binding of the somatostatin analogs to somatostatin receptors. Somatostatin is a peptide hormone naturally made in the body. Its role is to be the body's turnoff in the immune system, in the endocrine system. It stops all endocrine cells from growing. It stops endocrine cells from making hormones. We're talking now about neuroendocrine cells. These are not related to, for example, sex hormone making cells. That's a different type of endocrine cell. But somatostatin can stop insulin from working. It can stop serotonin from working and stops these things from being released. It also stops the neuroendocrine cells from growing. In addition, by stopping the production of hormones from endocrine cells, it can be extremely effective in controlling hormone release syndromes like carcinoid syndrome, and can stop the diarrhea and flushing from being so severe. Side effects are usually not severe. The most common side effects are gastrointestinal, and actually most of these gastrointestinal side effects are due to a reduction in pancreatic enzyme production, and if pancreatic enzymes are supplemented, the increased bowel movement frequency and increased gas production and bloating and distress can often be improved tremendously. They're uncomfortable because they're intramuscular injections. They can cause gallstones in patients who have a gallbladder, nausea. Sometimes blood sugar goes up a little bit, sometimes it goes down a little bit, but very few people that are not already diabetic become diabetic. That's actually quite rare. And it can cause bradycardia, a little bit of a slowing of the heart rate in a few people. Natural somatostatin, which has all of these wonderful effects, has a half-life of only about 3 minutes. So people have made analogs of somatostatin, which are then used for therapy. These analogs can last for a long time. Octreotide and lanreotide can last for about 90 minutes, but in the long-acting formulations, they control carcinoid syndrome for 4 weeks straight, or control cancer growth for 4 weeks with one injection of the long-acting lanreotide or octreotide LAR. The study done with octreotide showing its anti-cancer effect was called PROMID. This was a study done in Germany. Half of the people got octreotide in standard dose and half got placebo. And you can see that the so-called progression-free survival was markedly increased. It went from about 6 months to 15.6 months before the cancer started growing. The techniques used for measuring cancer growth were a little different than today, so we can't compare it directly with the study I'm going to tell you about right now, which is the clarinet trial. You can see from the yellow letters on the top how this peculiar name ends up spelling clarinet. It really is a bit of a stretch. But in any case, this was a wonderful study randomizing patients between lanreotide depot and placebo to see how effective it was to have lanreotide. When this was done, the difference between control of cancer with placebo and control of cancer with lanreotide was marked. The lines represent what we call progression-free survival. You can see that at 27 months, 62% of patients are still doing fine with no cancer progression versus 22% of patients who got placebo. Cancer had progressed in all but 22%. So there's a huge difference. The study has been further carried out, and it turns out that there's a 33-month period of cancer control on the average with lanreotide, and half of the patients cancer was controlled a lot longer. We've seen cases of 5 years, 10 years or more of cancer control. Excellent therapy with minimal side effects. In addition, lanreotide also causes a reduction in diarrhea. Most people who are treated with lanreotide do have a response with their carcinoid syndrome, and it's both octreotide and lanreotide actually are effective in both indications, although the official FDA-approved indications for octreotide are treatment of syndrome, diarrhea, flushing, and the approved indication of lanreotide is treatment of cancer. There's obviously a big overlap, since if you have carcinoid syndrome, you have a carcinoid cancer making the syndrome. So just be aware. The Clarinet trial did not include patients with lung carcinoid, so there is now a multi-institutional trial known as SPINET using lanreotide in lung carcinoids, and myself and Diane Reedy, who will be speaking shortly, have been very much involved in getting this going, and we do have it available for treating lung carcinoids with lanreotide. 2 people get lanreotide to 1 person who gets a placebo, but if anybody gets a placebo, they get lanreotide also if there's any progression. So it ends up that everybody on the trial has the opportunity to have lanreotide. There's another somatostatin analog that I've been very much involved with called pasirotide, which has a little bit more binding to neuroendocrine cells than either octreotide or lanreotide. And in one trial, it looked like there was a 5-month benefit in progression-free survival compared to octreotide. More studies are hopefully going to be started soon. Okay, now one more thing that I want to talk to you about with the somatostatin binding to somatostatin receptor is using the somatostatin as a means of delivering a nuclear payload. The somatostatin, which is right here, and the part that sticks to the cell is in blue. This sticks to the neuroendocrine cell. And attached to it through this linker is a molecule, in this case lutetium-177, which is able to kill cancer cells, and it will kill cancer cells only when this sticks to the cancer. You can also substitute gallium-68 right here in that same spot, and then when it sticks to cancer, it shoots out a diagnostic ray that can be used for a PET scan. So we have a potential here for wonderful therapy and diagnostic technique. This is another picture of the concept. In this case, target means neuroendocrine cell right here. Ligand means octreotide or a relative. A linker connects it to the so-called chelator that holds the radioactive material. We use gallium-68 right here if we want to have a scan, and we use yttrium-90 or lutetium-177 in this cage if we want to have therapy. You release it into the bloodstream, you get it to stick to the cell, and then the complex of the target and the somatostatin analog gets internalized inside the cell where it is stuck, and rays shoot out that end up being lethal to that cancer cell and cells in the vicinity. Lutetium-177 is particularly nice because it has a beta particle that is released that travels only 2 millimeters. That's about maybe a 1/16 of an inch, so there's very, very little collateral damage. It doesn't do much to the rest of your liver, for example. If you have 20 liver metastases, you could nuke your metastases without the rest of your liver. So you can think of this as a molecular cruise missile with a molecular nuclear warhead on it. It's really pretty exciting. A large randomized trial which we did comparing octreotide in double dose, namely 60 milligrams every month of octreotide LAR versus the lutetium-177 product, PRRT, to see how effective PRRT was done. That's known as NETR1. The difference between the two groups is dramatic. The average time before cancer started progressing when people got 60 milligrams instead of 30 milligrams was only 8.4 months. With NETR1, most people are still doing wonderfully. This analysis was done close to 30 months, but even today, most people have never had a recurrence. If you extrapolate out the curves for whatever that's worth and see how far they go, just to get to the cross line at 50% of patients still being controlled is around 40 months after treatment. So this is remarkable. This is done with just 4 injections, one time every 4 weeks times 4, and then it just controls the cancer for years to come. So this is a remarkably exciting thing. It looks like there's a benefit in survival, although we want to have longer follow-up to absolutely prove this. But if you look at people who died getting placebo, it was 35 versus 13 with lutetium-177. So it looks like it not only keeps the cancer from growing, in many people it will shrink the cancer, and it looks like it also may be really a major benefit in prolonging survival. We have a trial right now called the Expanded Access Clinical Trial of lutetium-177, which is the same as the NETR1 experimental group. In other words, every single person gets PRRT, nothing is randomized, using lutetium-177 dodeoxytriatate or dotatate, or brand name Lutathera it's called, for 1 injection every 2 months times 4. So we have this available at Montefiore, and it's available at several places around the country now. We're hoping that this is going to get approved in the near future, and it's going to be able to benefit a lot of patients. The clinical trial right now is with midgut carcinoid. We're hoping that in a matter of a few months, if the approval includes other sites like pancreas and colon and other things, that it will be generally applicable. It's also important to know that a lot of new trials with PRRT are on the way, using different types of materials. Instead of using dodeoxytriatate, you can use DOTA, that same linker, combined with a lot of other molecules to stick to the neuroendocrine cells, so-called antagonists instead of agonists. People are doing PRRT with other biologic drugs, PRRT with chemotherapy drugs. It's just opening up a whole new world. New isotopes using alpha emitters instead of lutetium-177. We don't know whether any of these things are better, but they're all in clinical trial, and we hope that this field is going to rapidly advance like other fields. And actually, Dr. Richard Baum, who will be speaking by Skype later this afternoon, is one of the pioneers in the field in Europe, and he'll be mentioning some of these things, and I'm sure Diane Reedy will in her talk as well. Now, gallium-68 is something that we mentioned briefly. When you put that particular molecule in the chelator cage to bind to the somatostatin receptor on the cells, you can make a scan. The scans that you get are PET scans of extraordinary quality. It's maybe 10 times better than Octria scan. It's so good that it's going to completely replace the Octria scan very shortly. And I think anybody who has the opportunity to have one, that's really the test to get. This is a CAT scan of somebody with metastatic neuroendocrine tumor in the liver. This is what happens if you do a gallium-68 PET. You see these tumors light up like light bulbs. You see exactly where they are. You see more than you can with the Octria scan, or more than you could see with a CAT scan. CAT scan's already normal after 1 cycle of PRRT. But the patient still has cancer, but you wouldn't know it if you didn't do the gallium scan. After 2 cycles, the patient's in a remission, and you don't see any sign of cancer anywhere. This particular patient, unfortunately, did not go for a really long time, and in 1 year had a recurrence, but it shows up faster on gallium-68 than anything else, and you know that it's time to start therapy. This is an Octrio scan over here, and in exactly the same patient, this is a gallium-68 PET. The information is actually way better than this because it's fused on a CAT scan, and each one of these things lights up on the CAT scan, like I showed you, like a little light bulb. But just comparing the nuclear medicine imaging, you can see it's way more sensitive. We did a study when I was in California, in conjunction with the UCLA nuclear medicine department, with 100 consecutive patients that were scanned with gallium-68 dotatate. The intended management changed in 60% of patients. People that were ready to have a liver transplant had it canceled because they had a couple of bone metastases that would have just kept growing if they had a new liver. people that were ready to have surgery had their surgery canceled because they had 20 other metastases that the surgeon didn't know about, and that sort of thing. So I think this is going to become a standard, very important test for staging new patients and for doing at a time when it's going to influence therapy. It's not something that needs to be done every month, every 3 months, just do it, because it's there, but when you need it, it's invaluable. Okay, this is a picture of the stone heads on Easter Island, also known as Rapa Nui. One of the most remote places on Earth in the middle of Polynesia is one of the wonders of the world where these things have been standing for these heads have been standing for hundreds of years, made of solid rock in an area that's all grass, and how they get standing there and what's happening, nobody really understands very well. Somebody went to the Easter Islands and was looking at these heads and got a brilliant idea that if he brought some dirt back to analyze in the lab, that he might have struck gold. He thought maybe there would be some antibiotic made by an unknown fungus growing in this isolated ecosystem that had never been looked at before. And sure enough, he found it. So the antibiotic was named after the island where these heads are found, known as Rapa Nui. So they called the antibiotic Rapamycin. And they had no idea what it did. But it worked on an enzyme that not only stopped certain microorganisms from growing, but it actually stopped cancer cells from growing. And this enzyme regulated how fast the cells grow and their metabolism and how long they live. It was a central regulator in cells. So they thought it would sound very scientific if they called this enzyme in cells MTOR. MTOR means mammalian target of rapamycin. So now you think you know what it does. You have a drug, and it's called MTOR inhibitor. And you have an enzyme, and it's called MTOR. So you can kind of go in a circle, and you don't know what's doing what. Well, anyway, it was so important that it stimulated generations of research, and now people have discovered that MTOR is actually a lot of different enzymes, and it's a whole important mechanism. And neuroendocrine tumors have mutations that make the MTOR a very, very important regulator of how long they live and how fast they grow. And we can now treat neuroendocrine cancer with MTOR inhibitors. Rapamycin, the original version, is known as sirolimus. That's the generic name of rapamycin. Novartis made everolimus, which is a slight modification of that original molecule to be a user-friendly pill. And now we're using it in neuroendocrine cancer, and it's turning out to be very, very effective. RADIANT-3 clinical trial in pancreatic neuroendocrine tumor is the study that led to the FDA approval in 2011. Everolimus 10 milligrams per day versus placebo. Progression-free survival increased from 4.6 months to 11 months. Some people were able to stay on it for years, and even though it can cause side effects, including fatigue, mouth sores, diarrhea, skin rash, and other side effects, the side effects usually are very, very minimal and sometimes completely go away if the dose is reduced. So if people can't tolerate 10 milligrams a day, they could have 5 milligrams a day, 5 milligrams every other day. But if you get a dose that works, I have people that were on that original trial and have been on it for 7 years with progressive disease resistant to chemotherapy and somatostatin analogs before they ever tried. So it really is amazing. This is a picture of how tumors actually get better, even though the goal of treatment is what we call stabilization, progression-free survival control. You can see that almost everybody has shrinkage of cancer. This line at 0 is how big the tumor was to start, 3 centimeters, 5 centimeters, whatever it might be. And this is the percentage shrink when they take everolimus. And you could see that there were only 20% of patients where there was any growth. Everybody else, it was stable, and in most people, the tumors actually shrank to various degrees. This graph is made by 191 vertical lines. Every patient is a vertical line, and almost all those vertical lines are below 0. The reason a few, this is over here, in the placebo group, you can see that almost everybody's cancer grew, and there were only a few people where there was any response, and these people were allowed to be on octreotide while they were on this therapy, and it may very well be that these patients were responding to octreotide. So it's a dramatic difference between the two and led to a rapid FDA approval. Another very important study called RADIANT-4 was done in neuroendocrine tumors of the intestinal tract and lung. These are what go by the nickname of carcinoids. Okay? Same dose, everolimus versus placebo. This demonstrated 52% reduction in risk of progression or death, increase in progression-free survival from 4 months to 11 months. It controlled cancer just about as well. It's really almost superimposable in intestinal and lung carcinoids as in the original trial with pancreas neuroendocrine tumors, and has now been approved for that indication. So it's really a remarkable drug. There's new research going on right now trying to find better ways of using mTOR inhibitors and using stronger mTOR inhibitors instead of inhibiting just one enzyme called TORC1, which is what everolimus does. We now have trials that inhibit more than one enzyme. I did one with so-called CZ223 that had extraordinary control of cancer. We're still trying to figure out where these are going to fall in clinical practice, and I would say using these types of advanced mTOR inhibitor programs are still investigational. Next item. This is a remarkably graphic picture of what blood vessels look like in a cancer. Cancers induce the formation of new blood vessels. We call this neovascularity. Windy, twisty, small, weird blood vessels that you almost never see anywhere else in the body. Okay? Maybe in certain healing wounds, maybe in a placenta, but this isn't something that's normal in the body. But cancers, this is routine. And it turns out that neuroendocrine tumors have a tremendous amount of this type of blood formation in the neuroendocrine cancer, and we can use anti-angiogenic drugs, drugs that attack these blood vessel formers, to work. And we're still trying to figure out, again, how this all sorts out in clinical practice, but I just want to let you know what's going on and stay tuned. Bevacizumab goes by the brand name of Avastin as a monoclonal antibody to vascular endothelial growth factor that's necessary for these blood vessels to grow. In a trial that was done early on, it had a 24% response rate done by Dr. Kulke. There were trials that were done at Stanford and at UCSF using this same drug in combination with oxaliplatin, 5-FU type medication, and again, bevacizumab with good tumor responses in certain individuals. And based on this, some large randomized trials were done, one in people with carcinoid tumors, bevacizumab, which is the anti-angiogenic plus octreotide, versus interferon plus an anti-angiogenic. Okay? And in that trial, the results were remarkable for tumor response, but the side effects were more with the combination, and it's not yet ready for prime time. Similarly, in pancreatic neuroendocrine tumors, we have a trial of everolimus plus octreotide versus everolimus bevacizumab, the anti-angiogenic and octreotide. Again, responses were much higher with the combination, but also more toxicity. And again, not ready for prime time. We have to figure out how to use this concept in therapy. Sunitinib is another anti-angiogenic type drug that inhibits lots of what we call tyrosine kinase growth factors, but most importantly, ones involved in blood vessel formation. And in these patients that were randomized to sunitinib or placebo with pancreatic neuroendocrine cancer, the results were very good, comparable to everolimus in pancreatic neuroendocrine cancer. And toxicity was normally tolerable if the dose was adjusted appropriately, otherwise it can make you sick. Pazopanib has recently been subjected to clinical trial, another anti-angiogenic looking very good in carcinoid tumors. Pazopanib versus placebo, the trial is now closed, and results hopefully will be released shortly, and we're hopeful that this will be another drug in our armamentarium. Finally, in the world of treating cancer, cytotoxic chemotherapy that means using ordinary cancer chemotherapy for pancreatic neuroendocrine cancers, has a role. These drugs are not very effective at all in other types of neuroendocrine cancers, but in these particular foregut tumors, they really are. So streptozotocin has a 39% major tumor shrinkage rate. Another combination being used now, temozolomide and capecitabine, also known as Temodor and Xeloda is the brand. Very high response rate, 71% partial response rate. That's a major tumor shrinkage. And people are tolerating it well. And even though it's chemotherapy, it's a pill. A randomized trial was recently done with temozolomide plus temozolomide capecitabine combination to see whether the combination is necessary or plain temozolomide is just as good. That's recently been closed, and again, we're going to have results of this very shortly. The last thing I just want to mention very briefly is the new drug for carcinoid syndrome. There's a drug called tilotrestat. Tilotrestat inhibits an enzyme that's essential in making serotonin, and a randomized trial was done comparing people with placebo and 2 different doses of tilotrestat, after which everybody got high-dose tilotrestat. Results were extraordinary. The bowel movement frequency was reduced by another 35% in people already on somatostatin analogs. People that were confined to home because they couldn't get away from a toilet were now able to go out and live a much more normal life, and the responses were quite durable. It also reduced the 5-HIAA level by more than 50%. The drug we're very, very hopeful about, and hopefully we'll be seeing a lot more of this in the near future. We're hoping for an FDA approval in the next few months, and we're hopeful that this may help reduce the risk of cardiac carcinoid heart disease and other problems. Last thing I wanted to tell you was I just feel so strongly about neuroendocrine tumor centers and the use of multidisciplinary tumor boards. This is from an old Indian proverb about the blind men and the elephant who had never seen an elephant before. They were all feeling different parts of the elephant. And so these men of Hindustan disputed loud and long, each in his own opinion exceeding stiff and strong, though each was partly in the right and all were in the wrong. It wasn't until they sat down at the table they realized that the elephant wasn't just a trunk, which they thought was a hose. It wasn't just a tail, which they thought was a rope. Just wasn't a leg, which they thought was a tree trunk. Similarly, with neuroendocrine cancer, you have to have everybody sitting around a table and talking. Instead of the elephant in the room, we have a zebra in the room. And instead of 10 blind men, you have 10 different medical specialties, each one somewhat blind to the other specialties' capabilities. And when people sit down and talk to each other and understand about neuroendocrine cancer, decisions can be made that are far more valuable than any one individual by himself can possibly come up with. So I'm a big proponent of multidisciplinary teams, and I encourage everybody to take advantage of the multidisciplinary teams scattered through the country when complex neuroendocrine tumor problems arise. So thank you very much.